Hi, my name is Madeline. I'm a third-year medical student at the University of Rochester in Rochester, New York, and today I will be presenting our research entitled Emergency Medicine Resident Perceptions of Sexual Assault. Thank you for tuning in. I have no disclosures to report. I do want to make a brief mention that this presentation unsurprisingly discusses sexual assault. If this is a triggering topic for you, please proceed with discretion. To begin with an introduction to sexual assault in the US and the care of the sexual assault survivor in the ED. Sexual assault is an unfortunately prevalent issue in the United States, with recent estimates that approximately 20% of US adult women and 1.5% of US adult men will experience rape over the course of their lifetime. Annually, this translates to over 1.4 million women and over 200,000 men experiencing rape. While there is little data regarding the number of sexual assault survivors who then present to the ED for medical care, one such study found that approximately 4.2% of assault-related visits to the ED were sexual assault-related. Therefore, there is an appreciable volume of survivors who are going to the ED for medical care. And while the use of sexual assault forensic examiners has grown dramatically in recent years, EM physicians are still the primary providers of medical care to sexual assault survivors in the emergency department. However, EM residents receive little training on how to approach survivors from either a procedural standpoint or a psychosocial standpoint. For example, one study of program directors found that 40% of directors responded that their programs require their residents only view a forensic rape exam and had no requirements on completing one themselves, and that 70% of the program directors surveyed responded that their residents receive only between 1 to 5 hours of didactic education on the topic. Perhaps unsurprisingly, given the lack of formalized education on this topic, previous literature has found resident procedural and knowledge skills deficits, which improved with targeted didactics. One area that has yet to be explored is EM resident perceptions of sexual assault. Why is this important? Well, healthcare worker bias against sexual assault survivors has been shown to correlate with a decreased quality of care. One way to measure these biases is to look at rape myth acceptance. Rape myths are defined as prejudicial, stereotyped, or false beliefs about rape, rape survivors, and rapists. Rape myth acceptance has been studied in other healthcare worker populations like medical students, nursing students, and nurses. However, to our knowledge, there have been no studies on rape myth acceptance among EM residents. We found this to be an interesting topic to explore, both given the lack of knowledge on the subject matter and additionally, given the importance of this in that EM residents are interacting with sexual assault survivors, and previous research has shown that bias against survivors can impact the quality of care that they receive. Our methods was administration of the Illinois Rape Myth Acceptance Scale, which is a validated survey utilized in a variety of published literature, and it consists of 45 questions utilizing a 7-point Likert scale, in which respondents are asked to rate their degree of agreement with rape myths from strongly disagree to strongly agree. There are subscale categories of common rape myth themes. For example, she asked for it, he didn't mean to, it wasn't really rape, or she lied. Data from 19 residents, which is 45% of the program, were analyzed, with incomplete surveys not included. The average score on the Illinois Rape Myth Acceptance Scale was a 63 with a standard deviation of 19. In the bottom is a graphical representation of the average and standard deviation over the range of possible scores, with 40 corresponding to an ideal score, with a respondent responding with strongly disagree to every rape myth, and a 280 corresponding to a non-ideal score, with a respondent responding strongly agree to every rape myth. The degree of rape myth acceptance was significantly higher for the she lied subscale than for the other subscales listed below. In conclusion, to our knowledge, this is the first study attempting to assess EM resident perceptions of sexual assault. Rape myth acceptance was greater for myths related to lying about having been sexually assaulted than for other subscales. We hope that these results can help shape EM residency training by highlighting the importance of addressing bias against sexual assault survivors, and in particular, bias regarding the myth of false accusations. Thank you for your time. These are our references.